I'd like to call the meeting of the Quality and Patient Safety Committee to order. Will the secretary please call the roll? Present.
Director Sorrell? Present. Director Webster Cross is absent. Chair Bott?
Present.
And remotely attending, Ms. Merriweather?
Present.
And also present, non-director member, Director Singh. You have a quorum.
All right. Thank you. The next regular meeting of the committee is scheduled to be held Friday, August 8th at 9 a.m. The first item on today's agenda is public testimony. As a reminder, written testimony will not be read into the record, will be included in the official record of this meeting and posted to the website. Madam Secretary, do we have any speakers who are registered to provide in-person or virtual oral testimony or submitted written testimony?
We did not receive any registrations nor any written testimony.
Okay, thank you. The next item on today's agenda is the proposed Georgia Hospital Division Chair initial appointment, which will be reviewed by Dr. Lawrence Smith, Chief Medical Officer. Dr. Smith here? No.
I'm here.
Remotely? All right, well,
Yes.
welcome, Dr. Smith. We're excited to have you and look forward to working with you. Thank you so much. Congratulations.
Good morning. Thank you. Good morning. I'm respectfully requesting approval for the initial appointment of Dr. Oyokunle Abagunde for the Chair of Division of Gastroenterology under the Department of Medicine. Dr. Abagunde attended London School of Hygiene and Tropical Medicine in the United Kingdom. He completed his initial residency in family medicine at the Royal College of General Practitioners in the United Kingdom, followed by an internal medicine residency at John H. Stroger Hospital of Cook County. He joined Cook County in June of 2025 and has interest in teaching and is a published author.
Thank you, Dr. Smith. I'd like to entertain a motion to approve item 3A, the one proposed Georgia Hospital Division Chair initial appointment.
So moved.
Second. Moved and seconded. Is there any discussion on the motion? All in favor, say aye. Aye. All opposed? Ayes have it. The motion carries. I'd like to ask Dr. Tom Petronikos, President of Stroger Hospital Executive Medical Staff, followed by Dr. Paul Allegretti, President of the Provident Hospital Medical Executive Committee, to provide any reports, present their medical staff action items, committee's consideration approval. Thank you.
Good morning, everyone.
Good morning.
I'm Neha Sheng. I'm presenting on behalf of Tom Patronakis for the executive medical staff of Stroger Hospital. First, I'll discuss a couple of highlights from the hospital-wide Quality and Improvement and Patient Safety Committee. This is from the May meeting. Some highlights include for radiology that we have improvement in our MRI and CT scheduling, and we are achieving our goal. Ultrasound wait times have improved, although we are still at a 41-day wait time for scheduling routine ultrasounds. We have some proposed revisions to the scheduling in place. Mammography wait times are still above goal despite adding 75 weekly slots, so staffing barriers are contributing to this. For interventional radiology, overall, our efficiency in terms of on-time starts and turnovers have been significantly improved, but staffing does still delay IR. Moving on to trauma, we've had preparation for our American College of Surgery verification, and that's targeted for mid-August. Our orthopedic response time has been improving, and neurosurgery response time, despite some staffing changes, has been sustained at over 90% for over 3 months. There's been some changes to the IR model and some changes for the trauma tertiary survey, which are improvements are underway. For hospital case management, we have sustained 95% compliance with initial clinical reviews within 24 hours of admission. We're meeting targets for discharge coding, and 35% of our denials have been overturned on peer review. We are working on improvements for social work, and average response time is about 2.8 days, but our goal is 2. So that's an area where we're working to engage social work a little bit more early. And then from some nursing updates from the summary from this meeting, we are doing well in terms of HAPI prevention, fall prevention, and stroke education. And we have some ongoing improvements for pain assessment, CLABSI and COUDI, and restraint use, as well as Texas. Also presenting the Credentials Committee report from June, and there are no notable findings. I do believe you have this in your information packets, but I'm happy to clarify or answer any questions.
Thank you so much. Any questions? Appreciate the update on the quality and patient safety areas. I think in future meetings we might want to ask more about that, but appreciate all the work there. I'd like to entertain a motion to approve item 3B, the Stroger Hospital and Providence Hospital medical staff appointments, reappointments and changes.
So moved.
Second.
Motion has been made and seconded. Any discussion on the motion? All in favor, say aye.
Aye.
All opposed? Ayes have it. The motion carries. All right. The next item is the June 6th committee meeting minutes. These were approved at the June board meeting, but are being presented for any further edits or corrections if needed. Are there any corrections need to be made to the minutes for June 6, 2025? I'd like to entertain a motion to accept item 3C, June 6, 2025 meeting minutes, the Quality and Patient Safety Committee.
So moved.
Second.
Motion's been made and seconded. Any discussion on the motion? All in favor, say aye.
Aye.
All opposed? Ayes have it. Motion carries. Next item is to review the OpEx dashboard goals and tactics by Donica, Austin, Kathy, Dr. Arnold, Turner, and Craig Williams. Good morning. Thank you.
Good morning, Chair. Good morning, Director. Good morning.
Good morning.
Donica Austin, Kathy, Chief Hospital Executive for Stroger. So first, before us, and thank you for the opportunity to share once again our OpEx committee dashboard. So on the first 2 slides, just kind of giving high level, we have one measure that is at or above the stretch goal. We have 5 measures that were better than the goal, 1 measure that is better than our baseline, and then we have 2 measures that we're continuing to work on. So if we would go to next slide and then next slide, we'll get into the data. Okay. Okay, so the first one before us is our patient experience, and we're incredibly proud of the work being done under our patient experience. The 2 measures of work are provider communication and our nursing communication. Our provider communication is performing better than or at the goal for the last 3 months. The June rolling 12-month top box is at 85.8, and June is coming in at 90.29%. So incredibly proud of the work being done by our providers. We've met our Q1 and our Q2 goals, and we're right on track to improving the efforts there.
Terrific. Can you, are you able to just speak to anything in particular that may have helped get us to this number, a positive increase?
Honestly, it's been really targeted efforts by the leaders in this area, really working on communication. We're looking at the 3 questions that are in the press gate related to physicians, and they're really focused on that and targeting those. We talk about it at the medical staff meeting, executive medical staff, and there's a real effort to really, really improve.
Great, thank you.
Also moving to nursing communication, we are again proud of the work there. We're performing better than or at the goal for the last 5 months. June, the 12-month top box coming in at 74.63. So we're really close to that stretch goal of 75. June is also coming in above the stretch goal, which is 75.79, and we've met again the Q1 and Q2 performance expectations. Nursing has been doing their leader rounding. They have the nurse leaders have also been working really with the frontline nurses to make sure they understand the measures. They are posted on the boards. They talk about it in huddles, so there's a real effort around nurse communication at the bedside.
Congratulations, great work on both of those items.
Thank you. Moving to clinical outcomes. For our mortality index, we are on track so far to date. We're at the 0.9 mortality index for the hospital overall, which is less than the 1.0. We are not at the target yet, which is the 0.8, and there are many efforts underway to continue to decrease there. With our patient safety indicator, so this is our PSI 90, we've met our quarterly expected decrease. April rolling 12 month is at 0.89, which is now meeting the goal, and the April month is better than the baseline. And so there's efforts underway for this work group as they're reviewing all the cases prior to coding, and we're starting to see some results. Moving to our sepsis bundle compliance, the rolling 12-month compliance rate is at 42.86. The monthly May compliance rate is at 42.31. We have not yet met the quarterly expectations, but again, this is one that is underway. There's a really new effort to really look at our sepsis bundle compliance, and we're incredibly excited about that. They're looking at optimizing their screening tools, streamlining their pathways, as well as educating the staff on sepsis recognition.
Thank you.
Thank you. Next slide, please.
Before we go to this next, any questions, comments from remotely or here?
Thank you. Moving to readmission. So we have two measures here, the COPD rate as well as our post-hospital follow-up. Currently on the COPD rate, we're currently meeting the stretch goal for the rolling 12 months. We've been meeting that stretch goal for some time for COPD patients. And then for the second goal, post-hospital follow-up, we're performing better than or at the goal for the last 6 months. June, 12 months of post-hospital average days, follow-up at 20.3 days, and June is coming in better than our stretch goal.
Great.
Okay, and then moving to the last two measures under our throughput, which is our geometric length of stay and our ED, excuse me, ED length of stay for ED discharge patients. So a lot of work being done on our geometric length of stay and even our length of stay, our hospital length of stay. And we're really proud of the efforts there. We've met our Q1 expected decrease in our geometric length of stay and are on track to meet the Q2. April rolling 12 month is at 1.59, average above the expected geo mean, and the April monthly is coming in at 1.1, which is lower than the month prior. Our ED length of stay, again, there's a lot of efforts being done in our emergency department to get to that stretch goal. We've met our Q1 expected decrease in our length of stay for treat and released for ED patients, and Q2 is really off to a great start. So May, the 12-month median is at 299 minutes, which is slightly below the target, which is 324. So that's a good thing. May is coming in at 274 minutes, which is better than our stretch goal, which is 288 minutes.
Great, thank you. Good progress here. Share our gratitude with the team.
Thank you so much.
If I could please highlight one thing. So under clinical outcomes, if you look at the second metric for PSI 90 composite, Just to refresh the board's, memory on an intervention that we introduced, towards fall of last year. We established a multidisciplinary committee that will do weekly reviews of all our mortality, morbidity cases, including PSI. So as you can see here, since that intervention, the numbers have started really getting really close to our stretch and, above our target. For mortality index 2, right now, I know there is a lot of threats there. However, that we hope to see, we know for sure there would be an impact on mortality index 2 because of our close to real time, review of these cases.
Thank you for that additional information. Any comments, questions?
Yes, very good work and improvement in what you're showing here. In recognizing, as you mentioned, the sepsis consistencies in terms of not yet reaching the baseline, that actually seems to be a trend that many hospitals across the, for this region particularly, but even nationwide have found. Have there been some general trends or indicators on what might be areas to help to identify those potential precursors, or is there an algorithm that's showing these are the number of indicators or diagnoses that might increase the likelihood of risk for sepsis, so that we could have additional activities in place to try to fend that off? Because particularly for that older population, that's becoming a more problematic issue. Even over the winter months, we saw that increase, but we didn't see significant drops of it during the summer, which may have been, perhaps in the past more of a trend.
Yeah, so two parts, with your question, right? How are we identifying all potential cases? How do we early identify those cases? Yeah. So we do have an algorithm that we use. On top of that, based on our success from, the multidisciplinary review, weekly review of these cases, we introduce the same process to all our opportunities, missed opportunities, and also those cases that were treated correctly. We were able to identify on time. We also added a sepsis coordinator who does concurrent review. So that review starts in ED, and we kind of trace those patients all the way through their inpatient admission. To answer the second part of your question, yes, we do know where our opportunities lie, and we are coming up with targeted interventions and training. As you know, Dr. Sorrell, it's going back and ensuring that all these new processes we are building into our review processes are sustaining, right? With the agency staff and everything, we need to make sure that they're following the process that we have put in place. That's one of our challenges. The team recently identified some issues related with documentation. It's not that cultures are not getting drawn. It's just the way, our EHR is set up, the time stamps for some of those collections are not being captured correctly. So we are trying to address all those issues, but this is an area that we will continue to focus on. We are happy to see the improvements we are seeing with the frontline workflow, how they are engaged in this work and everything, but we do have additional opportunities we will be focusing on.
Looking forward to hear how that incorporation of those new techniques and then what you're seeing may hopefully help to continue to improve that indicator as you've seen such great progress on the others. Thanks.
Thank you. And Director Sorrell, we asked Dr. Kaitis and the team, we'll have further discussion about the sepsis topic, just to learn about the intervention, how it's worked towards improvement. There's also the high reliability work that the system has undertaken that has an impact on this work as well. And I think all that we can do to continue to improve around sepsis mortality will be helpful. And I think there are things we can do that maybe also pioneer for health systems like ours across the nation. So we'll talk further. Thanks. Any other comments, questions?
Thank you.
All right, thank you. Thank you, Donica. Dr. Arnold, Turner for Providence Hospital site review.
Good morning. I'm Dr. Arnold Turner, Chief Hospital Executive, Providence Hospital of Cook County. Before you have the summary slide of the metrics that we're following at Providence as part of operational excellence. We have this month, we have two measures that are at or better than goal. One measure that was better than goal that kind of slipped back. We have one that's better than baseline, and two that are not better than baseline, but are moving toward the goals. Next slide, please. The first one is the survey return volume. We're still having some difficulty moving this metric. We have not met the quarterly goal for improvement from baseline. Quarter two is only through April, May to date. This data is delayed because June just ended, so more surveys will be coming in. But in the past couple of months, we made some efforts to focus on this and try to drive the return surveys up. So it'll be interesting to see how those efforts will pay off. That included having in the discharge folder a flyer reminding the patients to return the survey, put table tent reminders on the bed stand next to the patient's bed. Also, in the post-visit calls, the post-discharge calls, the nurse that's making those calls reminds the patient to return the survey. So we'll see if those efforts help generate more returns. In addition, on our hallway monitors, we include one of the slides there, a reminder encouraging patients to return surveys for all the services that they receive at Providence Hospital. The next one is nursing communication. Lower survey returns impact on this top box measure. June rolling 12-month top box is at 76.53%. June is coming in at 75%, I'm sorry. So far, we are meeting quarter two performance improvement expectations and are on track for improvement efforts. Next one is sepsis. Sepsis is the one that we were above goal. We kind of felt slip back in the second quarter, but the sepsis bundle 12-month for May is at 55.56%. We held steady for quarter one in 2025 and didn't trend down, but so far for quarter two, we are not meeting performance improvement expectations. With respect to falls, falls rolling 12 months have fallen above baseline, coming in at 19 falls for the last 12 months. We had 2 falls in May and 2 falls in June. Quarter one met improvement expectations, whereas quarter two did not. We have a lot of efforts focusing on falls to meet our target goal by the end of this year of the rolling 12 months. With respect to the last two that are both in the ED, our ED staff continues to do well. Left without being seen 12-month rate is at or better than goal, coming in June at 1.93%. Our goal is 2%, and the monthly score for June is 1.14%, almost at target, at the stretch target. Both quarter one and quarter two are meeting performance improvement expectations, and we have improved by over 2% reduction for each. ED's decision to admit to depart from ED has been at or better than the goal for 3 months. June rolling 12-month median coming in at 114 minutes. Target is 120. And June monthly median at 90, at better than the stretch. We have met quarter one and two performance improvement expectations. And I just want to say hats off to our ED staff. They put in a lot of effort to meet these goals, and it's paying off. A lot of teamwork down there.
Thank you, Dr. Turner. I express our gratitude to the team as well. And any questions, comments?
Nice work.
Yeah, thank you. Well, Craig Williams, talk about ACHN site review.
Good morning. It's Craig Williams,
morning.
Chief Operating Officer. I wanted to review the ACHN performance against our goals. Sorry, I'm not there today. I was actually on PTO, so joining remotely. I can tell you one measure is at or better than our stretch goals. 2 measures are at or better than goal, and 3 measures are at or better than baseline. None of our measures are in the red. So on patient experience, we actually have a multidisciplinary team that's been working to address the 3 patient experience goals that we have. On staff work together, we're performing better than baseline the last 4 months. June rolling 12-month top box score was coming in at 66.11%. June coming in at goal of 67.12. We met the Q1 performance improvement baseline expectations, performance improvement expectations, but Q2 did not meet the 0.6 point increase that we're planning for. On provider addressing concerns, worries, we're performing better than baseline the last 9 months. The June rolling 12 months top box is coming at 66.43, and June is coming in goal at 65.99. We met our Q1 performance improvement expectations, but Q2 did not meet the 0.5 point increase that we were planning for. On our top box care provider explains problem conditions. Again, we're performing better than goal the last 4 months, with our June rolling 12 months coming in 66.61, and our top box with June coming in at goal at 67.13. We've met the Q1 and Q2 performance improvement expectations for this top box patient experience measurement. So a lot good performance, I think, on patient experience. A lot of that work has been really focused on that first measure, which is staff working together, really trying to get our, from the time you arrive in one of our clinics, with that initial clerk interaction, really looking at that team and trying to improve their patient performance, but also handoffs between each of the various folks that work in the clinic, really trying to get staff to talk up that next level of care. On our HEDIS measures on breast cancer screening, we're performing better than or at stretch goal the last 6 months. June rolling 12 months compliance rate came in at 62.1%, and we've met Q1 and Q2 performance improvement expectations for this top box patient for this measure. On hypertension management, we're performing better than or at goal the last 3 months. The June rolling 12 compliance rates coming at 59.1. While we started to improve our compliance rate, we're just shy of meeting the Q1, Q2 performance improvement expectations. Part of it is we've been seeing our denominator grow, and while the numerator has been improving, we're just not quite hitting that measure. So we do have a team that's focused on value-based care, that's looking at closing all of the care gaps and is putting a lot of work into closing the hypertension measure. The last measure is around our patient empanelment. We are performing better than baseline the last 6 months. June empanelment volume was at 118,351 members. We're just shy of about 700 patients per our quarterly expected improvement. We have our case management team outreaching to bring in patients that are rostered to us, but not have been actually got into care yet. So we continue to grow there. The other thing we've been looking at, and we're not quite sure what to do about this, is our new arrival patient volume. We've seen a pretty significant decline, obviously from less new arrivals coming into the city, but also the established population of patients. We've seen a pretty drastic decline in their utilization of our services this year. So we're trying to really look at that and be proactive around trying to re-engage and understand where those patients are in care and care needs, and then decide, are they going to remain in the panels, or do we need to start to take them off the panels earlier because they're no longer in the city? So some work happening there, I think, will really eventually should allow us to provide more access to patients that want to receive care at Cook County Health, and that's our overall goal, obviously. Happy to answer any questions.
Well, thanks for joining us in PTO. Thanks to the team for the continued great work in progress here. Any questions, comments? Oh. I think, as we see some of the shifts in enrollment and the environment as it relates to patients, as a result of legislation, we'll want to continue to monitor and plan for some of that in the ambulatory environment.
Can I make a
Yes.
general statement? One trend we are seeing across the system is the improvement in the patient safety, patient experience domain. As you can see, all three facilities are showing consistent improvement for the past several weeks and months. So we will bring Ling and her team to the board meeting next month to share some of the highlights from the recent, interventions that the team has introduced. So we are excited about that trend.
Thank you. Yes, congratulations on that work and patient experience. Appreciate the team's work there. All right, next item is a report on substance abuse disorder and recovery support services program, which will be reviewed by Dr. Julie Nowinski-Concha. Good morning.
Good morning. Thank you so much for the opportunity to be here today and tell you a little bit about the substance use disorder and recovery support services programming.
We have slides. Yeah.
Yes, I'm pulling it up. Oh, thank you.
1 second.
Thank you.
I'll tell you a little bit about our philosophy of care while we're pulling them up. Our goals are to be patient-centered, multidisciplinary, have no wrong door to support patients regardless of their recovery goals. Next slide, please.
Yep. And before you go further into this, just for the benefit of the new board members, just describe your role here at the system.
Sure. I'm an addiction medicine and preventive medicine physician. I'm part of the Office of Behavioral Health and serve as a physician lead for our substance use disorder programming.
Great,
See
thank
patients
you.
at the jail in the Austin Health Center. So I'm going to do this quickly. So no wrong door, support patients, whatever their goals of recovery are, whatever substance they're using and whatever door they enter, have coordination across all of our care sites and have a team ready and able to provide quality care internally and linking to external partners in our regional learning health system. Next slide, please. I mentioned multidisciplinary. You want to spend just a brief time on our coaches. Our peers and our recovery coaches are the glue of our team. They are in all of our care settings. Many are in recovery themselves. Thank you to Sarah Elder, who's the director you see there. And New England Journal of Medicine recently highlighted the great work and the importance of this type of support embedded, which is our goal. Next slide, please. I also will just highlight that this work has been built on about $20 million in grants over the last decade. So the first case study I'm going to walk us through is our Bridge Clinic. Our Bridge Clinic was built to be the easy button to enter care and access care, meaning recovery support, substance use treatment, medications when available. This started back in 2018 as a pilot. Thank you to Core Center for hosting us, and greatly expanded in 2021 under a SAMHSA grant. Thank you to Dr. Jeff Watts of psychiatry, who's the PI on that grant. Yes?
What is the acronym SUD/MAT?
I greatly apologize for using an acronym. Substance use disorder medications for addiction treatment. Thank you. So this work has greatly expanded with this grant. It's a physical space as well as a virtual clinic available Monday through Friday, same day or next day access to medication treatment, which is we're very proud of. We have a community health worker, a coach, providers from all sorts of departments are engaged and involved. It serves as a training ground, and we refer to great partners in the community who provide more intensive psychosocial supports as well as methadone and other services. Again, it serves as an entry point. Next slide, please. Briefly, by the numbers, we touch a lot of patients, so it is the door in for many patients. This is 1 year of data, 612 unique patients touched, 1,800 outreach calls. So this is a population that can be hard to reach, hard to engage, lots of work to meet them where they're at, bring them in, re-bring them in, welcome them every time. A couple accomplishments, we launched a centralized access number. We have a social media presence. We work really closely with the state who runs the MAR Now, which is Medication Assisted Recovery Now. It's a hotline to access the medicine. We refer back and forth. And next slide, please.
We have a question.
Yeah.
So of the based on the, no wrong door model,
Yeah.
saying of that, the bridge is the largest proportion of how patients come into services of
It-
that, or,
It serves a critical role, especially for our hard-to-access patients. So that's right. So if somebody leaves the jail, for example, goes out, a couple weeks later decides they would like to engage, the easy button is to get them linked with a coach and a provider through the bridge and then get them to their medical home. If they live on the south side, they might be going to Inglewood, for example. And we have, a team available, ready to roll, because we know that when a patient says, yes, this is what I want, we've got to respond then. We can't give them an appointment in 7 days.
Right.
Does that make sense?
yeah. And then do you use, admission discharge transfer feeds to understand where folks are moving and to connect in that medical home system?
It's a great question, and there's a lot of key leaders working on that, and that's a place we would like to get. Dr. Nutter and the team's work to get there. Thank you for asking that. That would really help us with partners.
Did I see a question coming here? Go ahead.
Yeah. I've got two questions. You provide services Monday through Friday, and you do have this access number that I assume that's 24/7.
So yes, we would love to be 24/7. I mentioned that we're grant funded, and we are at this time only able to provide this Monday through Friday daytime. The state has the MARNOW hotline, which is available 24/7, and so there are people that enter. We do have access points available on weekends, such as the emergency department, the CTSC, soon to come the intake center, and we would love to be at the place where we are 24/7 someday.
And so the state hotline is available 24/7, 7 days a week?
It is, yep, it is, and they refer a lot of their patients to us for ongoing care. So the MARNOW hotline is an entry point, a first prescription for buprenorphine, for example, or a first appointment for methadone, and then they need to pass it on to someone else. And Cook County Health is one of the key partners that receives patients.
And so with the state hotline, do they refer patients to us?
That's right, they do. Yep, okay. They do. Thank you. It's a very nice partnership. Yes.
So is this bridge clinic a physical clinic?
So yes, it is. It started in 2018 as a physical clinic at the core center, and it remains present in a physical sense. But with COVID, we also created virtual options, and patients have really liked that. There's some great literature out there around how it improves engagement to offer virtual support. So many of our patients enter virtually via telehealth, but we do have, for our patients, for example, the case I've mentioned of leaving Cermak, right? Someone that doesn't have a phone, it's really important that we still have a physical place that someone can just come and show up, and that remains at core.
And that's at the core center?
That's right. Yep, that is at the core.
So I have a question about 600 unique patients, and then you have about 1,800, which means like 3 outreach attempts per patient?
That's right. That would be on average, and of course, there's some higher, some lower. But we, when a patient says yes, we keep trying to bring them back, even if it doesn't work swimmingly at first attempt. Key barriers do include phones. A lot of people don't have phones, and that's a big, big challenge. But we engage, and then we also try to make them aware that we're there. So even if that moment, if they're not ready to engage today, we're going to be here in a year, come then.
So that means that you already have to have a patient identified. So how does it work? People come in and say, I need this, and then your outreach attempt will be to keep them engaged, or is this outreach to identify people to bring?
Oh, thank you for the opportunity to clarify. It's to keep engaged. And we do have some outreach efforts, including being present at community events and whatnot, but this is an attempt to keep a patient engaged and get them the care they're looking for. I'm so sorry.
And does the grant cover some of the social barriers that might prevent care, such as having access to or phone cards or something to allow minutes on the phone for tele or for recovery services follow-up? Or has that been an area that we've been able to address?
There is some space in the grant to support some things, mostly around transportation. We try to use whatever the MCO plan is and what's available, and then we have Uber rides, for example, which has been hugely helpful in the last couple of months. Bus cards are helpful, Uber cards are more helpful. The phones is a challenge, and it depends on, and I know we're at time, and so but there are some limitations to what the grant will cover, and then the federal programs are limited. So it's a space where we'd really like to innovate and better address.
We have some more time, so I know that you have this other case study, so we can go to that and then come back to questions.
Yeah, I know there had also been concerns about whether those potential programs related to the phone or phone cards might be potentially cut. So that may unfortunately bring an additional barrier forthcoming.
It'd be an important space to keep innovating around. I can just highlight on the next slide some of the outcomes we wanted to share. So this is a SAMHSA grant. So we have Lighthouse Institute of Chestnut Health Systems as our evaluator, and they recently did an evaluation looking at about 18 months of data. I'll share with you the baseline demographics. You can see the majority are male, about 4 in 10 identify as African American, Black, 20% Latinx. This is about, very similar to the population at highest risk for fatal opioid overdose in the city, of significant burden of mental health and homelessness, and criminal legal involvement. So they looked at outcomes 6 months out, and they have a really good uptake of that 6-month interview. There was a significant change in patient-reported abstinence from all substances. You can see there, 35 to 66%. Of note, there were also changes we know abstinence is not everybody's goal immediately, and there was a significant change in number of days of substance use. Excuse me. There was also a 75% reduction in arrests in the 30 days prior. So we're so proud of the team and the work that is happening. This is Dr. Andrew Burke, head of family medicine, receiving the 2024 MACO Award for the great work at the Bridge Clinic. Next slide, please.
Have you seen any women? You got 71% male, but female?
Yes, we absolutely do. But you're right, there is a leaning towards the, and we have inroads in particular from the criminal legal system, and but it is more male than female, which is true of our program in general, and
so that mirrors the overdose rates, unfortunately, in Cook County as well, too, with them being predominantly male in that age range.
That's right. So the second case study we wanted to highlight briefly is our work around naloxone. This work, I want to give a shout out to Dr. Sedax of the ED, who was doing this with Chicago Recovery Alliance before naloxone was a word everyone knows. There was also a lot of work done between 2018 and 2021 to change policy at the state level, and then to change internal policy. Thank you to Dr. Chan, who was here, and Dr. Fegan at the time. And then in 2022, we were able to hand naloxone to patients, naloxone being a key resource, a key tool for our overdose response, and getting it in the hands of patients is the right, breaking down barriers to access. So in 2022, and these data look old for a reason. I promise we'll look at more recent data in a second. But what you can appreciate on the left is we had workflows, but they weren't necessarily easy. We had orders that needed to be entered. We had documentation that needed to happen. We made it happen, but there were hoops to jump through. So you can see on the chart that from July 2022 to February 23, we did have growth in number of kits getting into the hands of patients, up to 60 a month, and we did have growth in number of clinics offering, about 5. Next slide, please. And then, so that data is here, that's on the way left, and then what I'd like you to appreciate is that big jump in, I think it's August of 2024, where we made the right thing to do, the easy thing to do, with vending machines and distribution box at our hospitals and clinics. And we have since seen a huge uptake. I think in May or April, it was 400 kits per month with the vending machines and about 300 with the distribution boxes. Next slide.
Yeah, over time, because I think it's still really early, it'd be interesting if this trend continues, or whether it doesn't continue. Would we be able to chart any difference in mortality?
It's it's a really important question and important thing to look at. There are so many factors that go
I know.
into play, right?
Interesting to see
Which
it.
makes it tricky to make a correlation, a direct correlation, or even causation. But we know that access, we know there's no reversing an overdose in the community without this available. So it's a yes and. We also know that about 3 in 4 of our patients that use alone. So it's a yes and. We need this and other tools. But we're really proud and we're thankful for, so this is a vending machine, for example. You can see this at Core, Stroger, Provident, now at CERMAC. The court's really expanding. Great work by Jennifer Brothers, Sophia Petlowski, and Lydia Karch, and many others. You can see 3 of our clinics. This is GMC Austin and Robbins, with the team engaged on the ground, handing these kits out to patients. I'm so sorry. Yeah, it's, I want to say it's 18 months. Off the top of my head, it's around then. It has a good shelf life, and we do monitor how many we stock so that we're not stocking without it going. So we start with a smaller supply and then restock. Thank you for asking. Next slide.
So there has been substantial decline in overdose deaths in Chicago, at least close to like 20% in 2023 and 2024.
That's right.
Your question, I think you could say, oh, there are a lot of other factors, but still you can see, your intervention and actual decrease in mortality. And some people argue that it's because of naloxone in Cook County. I tend not to completely agree with that. So I wonder, you could actually think about your implementation over time, because it looks like your distribution and the decline in mortality, do not necessarily match. But, if you could do something to figure that out, I think it would be really awesome.
Yeah, thank you for that. And that's right. It's absolutely a factor, as we understand, but it's very likely and probably a multifactorial influence on that decline. And we have seen significant declines. We need to see more. It remains the leading cause in Cook County of unnatural deaths, and so we're not done, right? And that's right. A better understanding, access to recovery support services, access to medication, changes in the drug supply, lots of things. I will say with this, it's not just a box. It's really been a culture change. We went from people questions, are we going to tell people to use by making these available? So now I get it, and we're supporting our patients. And I also just want to thank Dr. Norwood and the health department as well for their partnership here. Next.
Is this a question or questions in need of an answer still? I mean, and maybe there's some opportunity to step back and see if we can get a better understanding of what's happened and why it's happened. Because the last thing we want to do is see the numbers go back up.
That's right.
And the only way to do that is to know what works and what doesn't. And so
Yeah,
it'd be nice to see if there's some way we can get a handle on that.
Yeah, I appreciate that, and we'll take that charge back to look at what we can understand and to make sure that inequities aren't remaining, that we see a drop for all. Yeah. And then next slide. These are just some of the tools, some checklists, and the health department, and just happy that the OB clinic is the next one to go online with this distribution, and that is going to happen this month. And next slide, and a little taste of what's to come. We're looking forward to really implementing the mental health and substance use disorder service line and engaging stakeholders internally and externally, really thinking through the Bridge 2.0 with all these new opportunities to engage across the system, stabilize that grant funding I mentioned, expand our psychosocial offerings both at the jail and in the community, and follow our key performance indicators specifically for populations that cross that substance use, criminal, legal, and housing insecure Venn diagram. Thank you so much for your time and your questions. I appreciate it.
Yep.
Thank you to our leaders for all of their support. And others.
One quick question. Are you all monitoring year-over-year awareness around this issue? How folks are understanding the importance of the tools available and various actions that are taken?
Can you say
Just awareness around naloxone use, awareness around the the fact that this initiative is happening among both patients and providers. That may not be something, it seems like anecdotally people are growing in their understanding,
Yeah.
and I don't know if that's helpful or not, but just something that came to mind. To show that the awareness as a result of this work is growing, because that's the first step in getting to the outcomes, and keeping to the point that was raised earlier about keeping the sustainability of the outcomes, awareness and then action. But
Yeah, thank you. I think that we can think through how to look at that awareness more, not just anecdotally, at the staffing level. It sort of relates back to stigma and stigma reduction and efforts, and I would love for us to think through that. And we have some new tools to help support patients and teams around naloxone, as well as other harm reduction tools, and what's available, how to educate, how to make it available, including test strips and other things. And we did do a survey last year of our patients to see what they wanted, which really guided all this work.
Great.
Thank you for that question.
We've got a couple more and then we'll close it. Go ahead, Director Garza.
Thank you, Doctor. Going back to the Bridge case study, the clinical outcomes, for that 2-year period, what was the total capacity of being able to serve that population? I know the number you got to is 366, or at least, I guess that's the total number, right, including the male, and I would think female are in there too.
They are.
Okay. Was that the total capacity?
So we have daily capacity in the shape of a recovery coach and an available provider.
No.
And so that number doesn't reflect capacity.
Right.
You are right that, there are days where capacity is lower, right? And then there's times where it's a plenty. We at the moment aren't limited by provider capacity or coach capacity with this team. But it could be, if we had an influx of demand,
Sure.
that could become a limit, and they are grant funded, and that would be important for us to sustain.
So why I ask is I was trying to understand what you attribute the large percentage of male engagement, just knowing that's often the challenge of engaged males in healthcare, especially in this type of care.
Yeah, so this does, sort of reflect the patient engagement in substance use understood generally. And we do work hard to have our coach team reflect our patient population, and we for example, many men who identify as African American Black are part of our team. I think that likely helps us with engagement. We have thought and continue to think with departments around how to make sure that barriers that are sometimes more unique to our female patients are also addressed. For example, telehealth is a great example, right? A lot of our mothers, cannot go to an appointment without having someone
Sure.
to care for their patient,
Yeah.
and so, or their children, their dependents.
Yep.
But we will continue to look at that and make sure capacity doesn't become a challenge.
Yeah, very, very good work.
Thank you.
Great. Did you have something?
Yeah, it's not necessarily a question, it may be a request. That as I was thinking about this, there are 5 million people in Cook County, and in some respects, this is a small problem. You look at a population of 5 million people. So I don't personally have an idea of what we're talking about in terms of the breadth of the program, breadth of the problem, how many people are involved. So some of those demographics would be helpful to really understand the nature of the problem moving forward, and even identify areas of the city that are most impacted by this. So this information is really helpful, but I think it would be helpful to have a lot more context about the problem itself.
Yeah, Director Harrington, I think as Dr. Nowinski mentioned, that we're one part of the fuller ecosystem with public health and others, so I think that it's good to have a sense of what our contribution and collaborations are. But thanks for your leadership on this. Thanks for the incredible work by the team, on an important issue, and appreciate the opportunity to hear more about it.
Thank you so much.
And just to respond to Director Harrington too, there are indicators that show the EMS call rates related to overdose deaths, and that tracking and we get actually month by month updates on that. does give us a very good idea of where the overdose calls are coming from. Now, we know that's not the actual number that actually undercuts the full number of people that are experiencing an overdose, but it gives us an idea where what they call the hotspots are. So we can identify what neighborhoods are having a higher number of EMS calls related to overdose and place more resources that all of us work together. That's why all of us were so excited and thankful for this presentation, Julie, and from UIC Rush and Cook County, and working together to provide those resources so that we can kind of increase the proliferation of providers, resources in those areas. It also allows us to see when there are shifts. Like over Father's Day weekend, there was an increased rate of overdoses that occurred because of what may have been either a change in the drug supply or the toxicity of the drug supply. So it allows us to respond fairly quickly when there are these surges in overdose care. Additionally, as the goals that Dr. Nowicki pointed out, being able to follow up now that we have decreased overdoses, how do we then shore up those folks post-overdose care? And being able to say, how do we continue to help with harm reduction, potential bridging toward linkages to care for services. So all of those, we can try to track those based on some of those call rates.
And as you speak, one of the things that makes me realize, we're talking about people that have overdosed, many of whom have died, I assume. But we're not talking about the number of people that are actually addicted to these drugs and stuff.
No, that number is still much higher.
Right.
So which is requiring, didn't mean to speak for you, the need for these collaborative efforts to address the issue too.
Yeah, and we're so grateful for all the partners. It really is a village, and we do use the data. For example, we know that Austin is a hotspot, and that is why we chose to have our methadone clinic launched in
If
the
you help us see that data so that we can understand the breadth of the problem.
Thank you, Director Harrington. Thank you, Director Sorrell. Thank you. Appreciate all the presenters today. Committee will not be going into closed session today, so if there are no other questions or matters to discuss, we move to adjournment of the meeting. No one online. All right. As the agenda is exhausted, the meeting's adjourned. Thank you so much.